Hello, everyone. Welcome to our live NCLEX RN review session. So if you're new here, we're currently progressing through day 19th of our 90-day free NCLEX review series, and we are going to cover a wide variety of nursing subjects, and we'll be dissecting 2,000 NCLEX questions with comprehensive explanations. So I want you to spread the news to your friends preparing for the NCLEX. Our classes are entirely cost-free. So don't forget to subscribe and activate notifications to stay updated on our latest content. And for more information, refer to the description box below. And we do appreciate your feedback, so feel free to share your thoughts or questions in the comments, and we'll gladly offer further clarification on any topics. Now, guys, we are also offering the NCLEX review course through our website. So please check out our website at www.stancoastnclexcoaching.com for tailored assistance. And the program emphasizes enjoyable studying. We're offering engaging lectures and a vast pool of 3,000 NCLEX style questions. And you are going to be able to explore to our 10-hour animated video course and 100 hours of prep time. So you can also utilize our on-demand video library and practice with mock exams to boost your confidence. And you can gain 6-month full access with over 200 NG and test questions for comprehensive preparation. So study at your convenience with our flexible platform, and Stancoast NCLEX Coaching provides continuous support throughout your journey. So today, guys, we are going to focus on nursing management for the aspiration pneumonia and infectious pneumonia. So let's delve into it. Now, let's identify first what this condition is. Well, the aspiration pneumonia is a very much serious medical condition, and it can occur when the oral or stomach contents are inhaled into the lungs, which can lead to the pneumonia. And this is a condition that is particularly prevalent among the elderly and those with certain medical conditions, and it can really pose a serious health risk to these group of people. Now, let's first understand the underlying causes and also the mechanisms of the aspiration pneumonia. So here we go. We'll start first with the oropharyngeal dysphagia. So what is this? This is the difficulty in swallowing, and this is quite common in the elderly and is a major risk factor. Again, this is the most common type of problem, especially in the elderly, and this will really complicate into aspiration pneumonia. Now, there's also that lack of protective airway reflexes. For example, like the swallowing or the coughing reflexes. Sometimes these can be lost. And for example, if the person will probably go into a surgical procedure, or let's say once they have completed their surgical procedure, any diagnostic test requiring general anesthesia, then definitely they are prone to having this kind of issue. Now, these reflexes can also be determined or it could be impaired due to so many reasons, right? And so with altered consciousness, this is going to be one of those. Alcohol drug overdose is another one. And for those people that have seizure disorders, or it could be stroke, or they might have some form of head injury, and I have said earlier about anesthesia. And for those people that might have some brain mass and severe illness, or let's say swallowing problems, can also lead to that. Now, if there is like a procedure, let's say intubation, or let's say putting in or creation of a tracheostomy or endoscopy, these can also lead to that loss of protective airway. Now, in some cases wherein there is going to be a neurological condition, so these are the following that can also lead to the aspiration pneumonia, such as the seizures, for those people that may have had stroke in the past, and also multiple sclerosis, for those people that are elderly with dementia, could be Parkinson's disease or myasthenia gravis. These can also contribute significantly to the risk of aspiration pneumonia. Now, for those women that are in their childbearing age, they could probably undergo some sort of obstetric procedures that will require anesthesia or, let's say, lithotomy position. Then they are also going to be at risk. All right. Now let's go into another factors here. Well, of course, if there are any issues with the gastrointestinal tract, for example, maybe esophageal issues like strictures or diverticula, or it could be tracheoesophageal fistula or acid reflux, maybe hiatal hernia, or let's say intestinal obstruction or abdominal distension, and also the presence of a tube feeding, okay? Or it could be the post-pyloric tube feedings. These can also predispose the patient into developing the aspiration pneumonia. Now, there's also that severity that is going to be dependent on the amount, let's say the volume that has been inhaled or has been aspirated by the patient. And this can lead to different kinds of problems in this type of disorder, okay? So for example, if the person had aspirated stomach contents, well, we know what's in there, right? So the gastric acid or the hydrochloric acid can lead to the development of a chemical pneumonitis, while if they are inhaling or aspirating the bacteria in the oropharyngeal part, then they are going to possibly develop that bacterial pneumonia because of the amount of bacteria that is present in the oral cavity. And we also have probably some inhalation or aspiration of vegetable oil. This can lead into lipoid type of pneumonia, and could be inhalation or, let's say, aspiration of some foreign bodies, and this can also trigger the acute respiratory emergency and can also lead to a bacterial type of pneumonia. Now, guys, I really want you to refamiliarize about the common pathogens that are going to be involved in the aspiration pneumonia. So we have here the Streptococcus pneumoniae. We also have the Haemophilus influenza. We have the Staphylococcus aureus and the gram-negative bacteria. So these are those organisms that can potentially also lead to aspiration pneumonia. Now, let's move right ahead with identifying the different manifestations of this patient with the aspiration pneumonia. And so there are several signs and symptoms that can give us clues in order for us to make sure that we are planning the care plan, and also we are reporting these assessment findings to the medical provider. Now, one of those signs and symptoms is the increase in the heart rate. Of course, tachycardia is going to be one, right? And the person will also develop fever, wherein there is now elevation of the body temperature as it's trying to fight off the bacteria or any harmful substances that may have entered the lungs. And so this is something that can develop even in just a short amount of time after they had aspirated maybe some food, or let's say medications, or maybe they aspirated on the water that they just drink after eating their meal, okay? And the person here will develop shortness of breath, and this again can develop as early as within just a few hours after the incident. And so when this happened, their patient will also feel like they just can't get enough air. And this is because the lungs are inflamed and filled with fluid, and it's going to make it hard to breathe normally. Now, the patient will also can have some cough, and this is the body's attempt to clear out the aspirated substance, or let's say the infection from the lungs. There are also going to be some rapid breathing, and this is another way that the body will try to increase the oxygen intake when the lungs are not fully effective. Now, guys, when you are checking your patient's vital signs, especially with the O2 saturation, and taking note into their skin color, there might be some bluish skin discoloration. That's not a good sign. That's really telling you that the body is not getting enough oxygen. That is hypoxemia. And so the patient here has lower than normal level of the oxygen in the blood. And as a result to that, the skin, especially around their lips and also the fingertips, can turn purplish. It could be bluish. And this can really indicate that the body isn't getting enough oxygen. Now, when you are auscultating the patient, you will notice that there might be some reduction of the breath sounds or airflow. And this is because of that certain areas of the lungs that are becoming quieter than usual. So basically, they can be diminished. And this can happen because parts of the lungs are filled with the fluid, or could be pus instead of the air. All right. So the diminished breath sounds can be assessed, let's say, in, let's say, a severe form of a lung disease, or it could start as just maybe a mild symptom or mild sign for this patient with a lung disease. But again, guys, when you are trying to prioritize the problems that you had identified to this patient, make sure that you are prioritizing those assessment findings that can lead to compromise of the ABCs, the airways, breathing, and circulation. All right. Some of these manifestations can only support the ABCs. Now let's talk about the crackle. So what is this? This is basically going to indicate that there is fluid in the small airways. And this is a bit like rubbing hair between the fingers next to your ear. So you try to do that. Kind of grab maybe a cluster of hair and try to rub it against each other near your ear. So the crackles will kind of like be varied. It can be fine crackles or it could be coarse crackles. So if there is more of like fluid collection in the alveoli, or it could be in the terminal bronchi or bronchiole rather, then when the air passes through this fluid filled areas, then it can create those adventitious sound. Now we'll talk about the pleural friction rub. And this is what we call as very rough. It's grating sound that is going to be heard, of course, with the stethoscope. And this is going to happen when there is inflammation of the lungs, especially in the pleura. And this is caused by that rubbing against each other. And so because of the inflammation in the lungs, the pleural friction rub can also manifest in this patient. Now, when you are percussing the patient's chest, you could start it maybe on the posterior, maybe in the anterior chest wall of the patient. When you do that, there are those certain areas that may sound dull instead of being hollow. And when there is that change, when previously it was kind of like hollow sounding or resonant, but if you are noticing that this is becoming dull, then there is probably fluid or solid material in the lungs where there should be air. Now, probably there is now accumulation of the pus or fluid in those areas. Then there is that consolidation of the fluid in those alveoli or terminal bronchioles. Now, we're also going to talk about the thick pus-filled mucus. Now, the mucus that the patients cough can be really thick and it might contain pus, and that's a significant infection in the lungs. All right, remember about the process, the mechanism, our protective mechanism inside the body, especially in the lungs. When there is now a invading substance, let's say in the form of an aspirated food or fluid, when it lodges into those airways, this can cause the migration of those neutrophils. And also it can lead into attracting other the chemical mediators that will try to fight off the invading substance. And this is really going to cause some problems here if we are not treating this patient in a timely manner. Now, guys, we'll talk about the diagnostic test. And of course, you probably have already identified this chest x-ray, which is basically the key diagnostic tool for the aspiration pneumonia. And initially, like, let's say maybe within just a few hours, maybe about 2 hours after the aspiration has occurred, then the view might, or the chest x-ray might appear or may reveal normal view of the lungs, but over time, maybe after several hours, it can show signs of consolidation and also other abnormalities indicative of the pneumonia. So you can probably see the changes within just 24-hour period. Now, for the treatment of the aspiration pneumonia will include several critical steps. And of course, we are going to make sure that we are clearing the blocked airway. And this is our first step. Okay. So if you probably are in the middle of, let's say, administering the medication of the patient orally, and they're probably eating their meal, and when they're trying to take one of the tablets, let's say, for example, and one of those tablets are quite big, horse pills, let's say potassium chloride, and all of a sudden, out of nowhere, your patient started choking, right? Because of that large tablet. And probably they have not really cleared their mouth before taking that medication. Maybe there might be some residual food particles in their mouth. And so at that time, when they are choking, you have to really suspect that there might be some food contents that went in together with that tablet. And so if probably a partial portion of that tablet has gone into the airway, yeah, that can be a real problem. So what we're going to do is really to inspect the mouth of the patient. We're going to remove as much as we can in order to prevent the entry of these additional food items into the airway. All right. And if there is a visible blockage into the airway, we really want to make sure that this is going to be removed. All right. Or for example, they might be coughing. Maybe they have a pre-existing issue, maybe thick, tenacious secretions, right? They probably have a pre-existing lung condition, but it's not like the aspiration pneumonia yet. And maybe they accidentally swallowed into that phlegm or the sputum, which can also lead to some more problems. And so we are going to really clear that airway. Probably we are going to use the Yankauer suction tip, and this is going to at least remove those superficial debris in the mouth, maybe secretions. And we are going to also manually remove those foreign objects. Again, possibly, maybe we can do some suctioning into the trachea. And also, if they have already the endotracheal tube, then we really need to clear out those particles as well. Now, in order for us to really fight off the infection, you are going to see here the antibiotic therapy that will be part of the treatment, okay? And this is the cornerstone treatment in order to address the bacterial infections, okay? Because if once the foreign body is going to be inhaled into the respiratory tract, remember that the mouth is abundant with all those natural or innate microorganisms, and it can migrate into the lower respiratory tract, and this can lead into bacterial infections. Now, another treatment here would be the use of the laryngoscopy or the bronchoscopy, and they are going to be very important to assess and clear the airways. Now, part of the care is the administration of the oxygen, and also if the patient is not going to respond to the O2 therapy, then they might need to be placed on the mechanical ventilator if they are not able to maintain enough oxygenation. And so we want to make sure that we are monitoring our patient during this acute period because they can deteriorate really fast. All right. Now, part of the care is to provide the patient with fluid volume replacement as ordered. Once the patient probably will start manifesting some decrease in their blood pressure, and this is not a good sign. It simply means that the body is actually trying to respond with the release of those systemic inflammatory or chemical mediators inside the body, and this can lead to widespread vasodilation and the patient will end up with low blood pressure and shock. All right. Now, when this happens, what we're going to do is to stabilize the patient with the use of the IV fluids, possibly the administration of IV boluses with the normal saline, or followed after by the lactated ringer solution in order to stabilize the blood pressure and to maintain blood supply to the other major organs in the body. Then definitely we're going to go ahead and do that as well. All right. Now, communication is key, especially when you are in the team. Make sure that you are notifying your charge nurse, also notifying the rapid response team, or it could be the medical provider. Make sure that you are giving them updates about this patient. All right. Now, part of the care is the correction of acidosis. If the patient will have significant hypoxemia, maybe they're now retaining CO2 with respiratory acidosis, we definitely need to address that. Okay. Now, for the nursing care, this is very important, guys. I don't want you to just focus in a few, but we'll have to really pay attention because this is going to involve a cluster of nursing assessments and interventions. All right. So with the aspiration pneumonia, our main assessment, or our first and foremost assessment action here, is to really assess and maintain a patent airway. We are going to check for any blockage in the airway. Of course, this will include the mouth, all right, and into the pharyngeal area to see if we can see some visible items or any food particles that may be adding to the problem. And so this is going to be the first step in order to assess a patient suspected with aspiration pneumonia. And of course, this will ensure that their airway is clear and they are getting enough oxygen. While you are doing this, it would be nice, so it would be really important that you are monitoring the patient with the pulse oximetry. I would put that as a continuous pulse oximetry monitoring, especially during the acute phase, all right? Because you can easily detect of any progression that can happen rapidly. Now, you're also gonna check for the oxygen saturation, like I have said. Make it a continuous monitoring for the O2 saturation, not just like within 5 seconds or 5 minutes or 10 minutes while you are delivering care to the patient. So here, while you are checking for any signs of obstruction inside, maybe difficulty of breathing, maybe they are still choking, or could be much more of the coughing. Sometimes they might continuously cough because that's a normal protective mechanism by the body. So they're gonna probably have those coughing episodes more often because of that large foreign body. And of course, you are going to also monitor for their breath sounds, because there might be some progression from normal breath sounds into the adventitious breath sounds. Now, guys, you have to really monitor the patients for any signs and symptoms of infection. This is a big deal, right? So one of those is to check for the elevation of the temperature. Could be foul-smelling sputum, or it could be congestion of the lung fields. So your auscultation would really help out in detecting for any worsening, all right, of this patient's condition. Now, the fever, of course, really is one of those early signs that the patient is developing an aspiration pneumonia, and also the foul-smelling sputum. Again, this is now going to signal that there is bacterial infection going on, all right? Now, the congestion or the abnormal lung sounds, maybe the crackles or the decreased breath sounds because of the presence of the fluid in the alveoli, this will lead into the diminished breath sounds. And again, this indicates that there is now fluid or infection inside the lung. Now, definitely when you are auscultating, or when you are moving ahead with the assessment, make sure that you're also looking into the patient's level of consciousness. You have to determine, guys, is the patient much more drowsy this time than an hour ago when the aspiration occurred? Yes, this is very important. The level of consciousness is an indicator. maybe the patient is now having some worsening of their condition. Maybe they are very difficult to arouse. Okay, maybe they are now becoming lethargic at this point. That's not a good sign. And also their gag reflex need to be assessed, their swallowing ability, and any aspiration risks. All right. Now here, guys, we really need to also check for the gag reflex, as I've mentioned, because this is actually the normal mechanism in our body to prevent any aspiration. And also the gag reflex is one of those protective mechanism that is not going to be there anymore, especially when their level of mentation is decreased. Okay, make sure you remember that when the level of consciousness is affected, then the gag reflex will also be diminished. So guys, at this point, you really have to refrain from putting anything inside the patient's mouth. Do not give any PO medications or any kind of fluids. No, not a good practice. So always keep in mind about the gag reflex diminishing, and this is to really prevent more entry of the foreign substances. Okay, now there's also a need for us to elevate the head of the bed. Okay, so what is the rationale for elevating the head of the bed? Well, of course, when the patient has diminished a level of consciousness, and of course the airway, especially the mouth, will not stop producing those salivary secretions, and they can dry up so fast as well. When their mouth is opened, this can make the secretions thicker, and this can also lead to some more problems in this patient. Now, especially if you're maybe treating the patient with some tube feeds, maybe they are a stroke patients that are receiving the tube feedings, then definitely it would also require you to assess your patient thoroughly. Is the aspiration caused by the tube feeding itself? Maybe there is increasing residual volume in the stomach that was not checked frequently, and so it's causing the food to back up into the esophagus, and finally it went into the patient's airway. All right, so make sure that you're going to report that as well. It might call for a stopping of the tube feeding at this point until this is cleared. Okay, now we are also going to have to pay attention about the patient's need to be screened for dysphagia. Okay, so what is this? Well, there are so many ways of actually doing this. Part of my experience as a neuro-stroke nurse, I did so many bedside dysphagia screening, which is basically one of our roles. So this is just like a very simple kind of dysphagia screen that we have been trained to do. And so we have to instruct the patient a few things. Let's say having to kind of try to swallow their saliva. And if they can safely manage that, then that's a good indicator. And also we're going to have to proceed in having them take a little sip of water. And if they can do that safely, then we are going to give them that corresponding value that they are able to manage any kind of fluid and so forth. There are so many other sections in the dysphagia screening. However, though, if the patient's dysphagia is much more severe, then definitely we need to get the attention of our medical provider, make sure that we are making proper referrals for speech therapy evaluation. And this is very important, guys, because they are specializing into dealing with the dysphagia status of the patient. So they can do a whole lot of treatment and evaluation that we can't do. All right. Now, along with that, once they are going to establish those, or once they have evaluated thoroughly the patient, maybe they have probably recommended the barium swallow to, or maybe the video swallow study is recommended, then we have to really wait and to hold any kind of oral intake in the patient, no oral medications, no oral fluids to be taken in by the patient up until the patient is cleared with a test. Okay. Now we're also going to have to keep in mind, guys, once the patient has that aspiration incident, do not resume any kind of oral feeding, including any oral fluid. No, this is a big no. And also, if your patient is not alert, right? They cannot follow instructions, or maybe they're drowsy or lethargic, it is advisable to not resume any oral intake of any sort of food or fluid. That is the recommendation. Now, for those patients, especially if the speech therapist has established those recommendations, maybe the patient is now going to be placed into a modified kind of diet, let's say thickened liquids or honey thick liquids or nectar thick liquids, or maybe the patient's food items will be converted into mechanical soft, or maybe the consistency of the food items should be the same in order to prevent any aspiration occurrence, then we definitely need to follow those recommendations as ordered by the medical provider. All right. And also make sure that you are observing the different precautions that will be ordered for all other oral intake. Okay. And so, guys, the speech therapy evaluation doesn't just happen once when the patient is in the hospital. Maybe if there is deterioration of the patient's condition, or let's say there is some kind of improvement, or maybe if you really need to make sure that the patient's dysphagia need to be reevaluated, and of course you have to really communicate this to the medical provider in order that we can retest, do another evaluation by the speech therapist. So guys, make sure that you're going to collaborate with them. Now guys, we are also have to identify other tube feeding safe practices. So what are these? Well, maybe you probably have known this in the past, but I just want to make sure that we're going to go over into these again because we just need to reinforce your learning as well. And so one of those is to assess for the correct tube placement. And this is basic nursing care. All right. And you might be asked simply about this kind of a scenario. So when you're doing the tube feeding, make sure that before you start giving that maybe intermittent tube feeding or maybe continuous tube feeding, make sure that you are checking for the correct tube placement. Well, how are you going to do that? Well, you have to keep an eye into the placement of the tube because there will be some documentation about which mark has been advanced in that nasogastric tube. Okay, make sure that we are noticing into how much length has been advanced or has dislodged, maybe from the last shift or the previous shift. Make sure that we are looking into their documentation, also looking into the placement by doing the auscultation. Right, when you are going to introduce some air via the syringe, we're going to introduce that to the tip of the nasogastric tube. And of course, you're going to listen to the epigastric area and listen for that air gurgling sound while you are introducing. That's one. Okay. Now, if you have to really want to make sure everything is well in place, then you can also use that litmus paper to check for the acidity of the gastric content. So you're going to aspirate a little bit portion of that gastric content and check it with the litmus paper to check if it's acidic. Well, of course, if it's acidic, then there's a higher chance that the tip of the nasogastric tube is well placed in the stomach. Now, if it's alkaline, then that's not going to be a safe sign, right? Maybe it's already dislodged into the airway. Now, if you are suspecting that maybe the patient had pulled the nasogastric tube, all right? Maybe the patient has accidentally pulled it because they are doing something else, and maybe with the tension that has been caused, maybe there is slight pull of the tubing, and that could really harm the patient if we are not going to evaluate the placement. So again, if this is an occurrence that would really compromise the patient, then call the medical provider. If there is no standing order or if there is no such protocol to do a abdominal x-ray, then make sure that you communicate with a physician or the medical provider. Hey, doctor, this is what happened to my patient. He accidentally pulled the nasogastric tube. We want to make sure that we are continuing the tube feeding safely. Would you be able to order a stat abdominal x-ray to check for the nasogastric tube placement? Yes, we can do that as well. So make sure that this is going to be obtained before you resume the tube feeding. All right, make sure you do that. Always keep your patient safe. All right, this is going to be one of those risk reduction protocols or nursing interventions. Now, we're also going to have to administer the tube feeding slowly. Okay, it is advisable that when you are administering the intermittent tube feeding, that you're going to do it via gravity, not doing the push, using the plunger. All right, so that way it will just allow the passage of that tube feeding, the liquid, to go into the stomach of the patient without any external force. All right, and of course, you really have to observe the response of the patient. Are they tolerating the food intake, or are they retaining so much of the food that they're not really digesting the food? And if that happens, we are going to check for the residual volume, making sure that we are aspirating the stomach contents. And if it's probably over 150 or 200, that is very significant, guys. Okay. And if the patient feels like, hey, I feel like I'm not really digesting my food, listen to your patient. If they are feeling full, they are not really emptying their stomach, that is not a good sign. And so make sure that you are checking the residual volume. And also, if the patient may have some sort of a tracheostomy or endotracheal tube, then make sure that you check the seal of the tracheostomy tube, and also make sure that before you proceed with the feeding, make sure that you have checked off all those possible loopholes. Okay. Now here, guys, we're going to talk about the need for us to prepare our patient in order for them to go into a special procedure. So for example, maybe if they have an order to go into an endoscopic type of procedure, maybe upper or lower endoscopic type procedure, or let's say any other diagnostic testing that may require the use of an anesthetic agent, a general anesthesia. Well, of course, that would require us to prepare our patient to be placed on NPO for at least 6 to 8 hours, but it would be safer to do it for 8 hours, right? And this is something that you definitely need to check, especially if that diagnostic test would require with the use of a general anesthesia because of its effect in diminishing the gag reflex. Okay, that's the reason right there. Now, here we have to also keep that safe practice. Make sure that we are checking the patient for food pocketing. And this is a very common occurrence, especially in the older population. When you're dealing with the dementia patients, Alzheimer's patient, if you are probably giving the medication orally and they are still eating their food, make sure that when you have given the oral medication, you better check their mouth. Have them open their mouth and make sure you do a good, thorough visual check into their cheeks, the buccal area, to check if there's any residual amount of medication that could just be hidden in those sites. Make sure that they swallow that, because this can really cause them to aspirate in those medication. And this is very common, again, in the elderly population. All right, so that's another safety measure. Make sure you are checking the patient for pocketing of medication or any food items. All right, now guys, let us going to shift into another topic here, and this is on pneumonia, not the aspiration pneumonia this time. So we are going to discuss about the pneumonia that is going to pertain about the community acquired and also the hospital acquired pneumonia. and we're going to compare their different causes and mechanisms and the diagnostic test. So let's go. And we will also make some definitions here, or let's define each clearly here. So pertaining to the community acquired pneumonia, or the CAP, this is that pneumonia wherein there is, let's say, an infection that will cause the inflammation of the air sacs, maybe in one lung or could be the both lungs. All right. And so here, the causative agents are the following, and these are the most common ones. We have the Streptococcus pneumoniae. We have that as a majority of the infections is caused by that one. About 60% of the CAP is caused by the Streptococcus pneumoniae. And we also have the Haemophilus influenza, which accounts about 15% of the CAP type of pneumonia, especially for those people that may have lung diseases or may have some weakened immune system, or the aerobic gram-negative bacteria, which accounts 6 to 10%. And these are your Klebsiella, or could be the Enterobacteriaceae, and they're going to thrive into oxygen-rich environments. They are aerobic. Yeah, so they can thrive so much more when they are inside the lung. Now, we also have the Staphylococcus aureus, which is going to count to about 2 to 10% for all the CAP cases. And they are known to really cause some skin infections, but they can also lead to severe pneumonia if they are going to migrate into the airway. Okay. Now, guys, let us talk about the risk factors. Well, one of those risk factors involved here is the altered mental status. Okay, so this can also be caused by the medications that they are probably taking, maybe some sedatives or some of those opiates, or let's say some antidepressants that might lead into some form of sleepiness, anticonvulsants as well. And this is definitely going to affect their level of consciousness, right? And they're going to be at risk to developing the pneumonia. Now, smoking is a major factor, as we know. I'm not going to expound that. And also alcohol. This is going to cause pneumonia. The reason that it will also weaken the immune system and increases the risk of the aspiration, especially. And when they're going to be sedate after maybe several bottles of any booze, and definitely they're going to be at risk to develop that pneumonia. If the patient has hypoxemia, of course, any toxic type of inhalations, pulmonary edema, which is probably a complication of congestive heart failure. Well, the buildup of the fluid inside the lungs, especially in the capillaries or let's say the alveoli, this is now going to create an environment where the bacteria can thrive. Again, guys, pulmonary edema can really cause the bacteria to thrive and create their own environment because of that watery or fluid medium. Now, uremia, which is going to be the presence of the waste products in the blood, this is going to be one of those factors that can also weaken the immune system. Also the malnutrition, wherein if there is poor nutrition, it can also weaken the immune system and making it harder to fight the infections. Now, guys, for those patients that are immunocompromised, especially the HIV patients, or it could be the AIDS patient, alcoholic, for those patients that are receiving corticosteroid therapy, maybe they have some Addison's disease that they need to take the corticosteroids lifelong, then they are going to be prone to developing the pneumonia. Or let's say for those patients undergoing chemotherapy or radiation, for those cancer patients, they are going to be exposed, or they're going to be predisposed to developing the pneumonia as well. So this is your typical community-acquired pneumonia. And this is quite related to the infectious microorganisms that we had mentioned. Now, here we're going to go back into the community-acquired pneumonia, which is basically going to happen when the patient is outside of a hospital or within 72 hours of admission. So please pay attention, guys, that the community-acquired pneumonia is going to develop outside of a hospital, or let's say it can happen within 72 hours after the admission. And again, our first type here is the typical community-acquired pneumonia. And then we are going to talk now about the atypical pneumonia. So what is this atypical community-acquired pneumonia? Well, the causative microorganisms that have been identified mostly are the Mycoplasma pneumoniae. This is the most common for the atypical type. Okay, this is what we call as the walking pneumonia. All right, and this type of microorganism can often cause milder symptoms. However, the patient may have contracted the chlamydial type of pneumoniae microorganism, which is another form of bacterium. This can cause respiratory infections as well, and this is very common in the younger population. Could be that the atypical pneumonia is caused by the influenza type A and B, or let's say the respiratory syncytial virus or the RSV, or it could be the Legionnaire's disease. Okay, so this is this kind of species right here, the Legionella species. They are a form of that bacteria that is found in water systems that can really cause some severe form of pneumonia, which is what we call the Legionnaire's disease. Right now, as we are going to transition into the hospital-acquired pneumonia. Okay, so what is this? Well, we're going to identify here first those causative microorganisms. Well, of course, they are going to be common in the healthcare settings. And these are your gram-negative RUDs, such as the E. coli or the Pseudomonas. And these bacteria are very common in the healthcare settings. And that's why they're called as hospital-acquired pneumonia. And most of these microorganisms are actually resistant to many antibiotics, especially with the Pseudomonas. Yes, and they are very hard to treat if the patient has that resistant type. Now, we are going to talk about the other microorganism, which is the Staphylococcus aureus. So this is going to include the methicillin-resistant Staphylococcus aureus, or the MRSA. All right. So this is also one of those difficult microorganisms. Okay. And you definitely need to put your patient in an isolation, contact isolation for this one, if in case they have this kind of type of pneumonia. So guys, what are the risk factors for a patient that may have had the hospital-acquired pneumonia? Well, some of those is the admission or the hospitalization, at least recent hospitalization within the 90 days. All right. So the hospital stays, especially if the patient might be admitted to the hospital for quite a long time. Maybe they've been just back and forth between the med-surg unit and they probably are deteriorating, and they will be sent to the ICU, and probably they're going to go back to the med-surg again, or maybe they're going to be discharged to the acute rehab, and maybe they are not doing well in the acute rehab. They're going to be readmitted to the acute care, back to the med-surg, and probably their entire hospitalization will probably last for months and months. And this is not really uncommon. Okay, so I've seen patients like this even in my previous practice. All right, now Another is that the patient who might be living in a nursing home, or it could be a long-term care facility. For those people that are living in close quarters, or let's say if they are requiring frequent medical interventions, they are going to be at a higher risk to developing this kind of hospital-acquired pneumonia. And for those patients that may be receiving intravenous antimicrobial therapy, yes, they can also be one of those patients that may have a resistant type of bacteria, or for those getting chemotherapy, it can weaken their immune system, making the infections more likely to occur. And for those patients that may have some kind of wound care within the last 30 days prior to the onset of the pneumonia, or let's say they might have some kind of invasive procedures, maybe some open wounds, this will really increase their risk of the infection. All right. So guys, I hope that you're able to understand the different mechanisms of how they're going to have either the hospital-acquired pneumonia or the community-acquired pneumonia. It is very important that for you to understand the different types, and they're also they're causative agents, in order for us to really plan the care, and also that we can prevent this from occurring into our next patient. Now, as we wrap up here, I just want to make sure that I'm emphasizing this, that the community-acquired pneumonia is going to typically involve more common bacteria like the Streptococcus pneumonia, while the hospital-acquired pneumonia often involves more of the resistant type and aggressive bacteria. And recognizing these factors for each type really will help us in the preventive measures. And also remember that with the early detection, and we can do an appropriate medical or nursing treatment, and this is really going to help the recovery of our patient. Now, this time we're going to talk about the another sign that there is an infection going on. There is inflammation, of course, and here we have fatigue. The patient will get so tired easily. They will not be able to tolerate a whole lot of physical activities like before, because their body's really working hard to fight off the infection, and they might also manifest some productive cough with an accompanying pleuritic chest pain. So they are going to cough up that very thick mucus, and this is, of course, the body's way of trying to clear out the infection, right? And so it's very important for us to really monitor for the color of their mucus secretions or the expectorate, and to check for any signs of the pleuritic chest pain, because this is going to be one of the complaints that they might have. They will have this sharp pain in the chest that will get worse when they are taking deep breathing, or let's say when they are coughing. Then they are going to kind of hold their breath. Remember about our discussion in the pleurisy or the pleuritis. Remember about the kind of pain that they're gonna end up holding their breath. They don't really want to do a whole lot of deep breathing, and so this can lead to some more problems, hypostatic pneumonia. And so guys, we are also gonna possibly see them with some difficulty of breathing, dyspnea, and of course the use of the accessory muscles. You might see them straining with their neck muscles or maybe their shoulder muscles in order for them to breathe. And of course, this is the body's attempt to really help to get some more air, right? And the tachycardia, which is going to be one of those manifestations that will accompany the shortness of breath and also the fever because of the increasing metabolic demand. Well, this can also lead to the tachycardia, right? Because of that increasing metabolic demand, the body will try to compensate. Now, we'll talk about the diagnostic test that will be ordered possibly by the medical provider. And of course, the topmost diagnostic test is the chest x-ray. Well, this is going to show us the pneumonia, the local area, or maybe if it's already spread, or maybe it's affecting different areas. So let's say, for example, if the chest x-ray is showing lobar consolidation, when it says that, lobar consolidation, So this simply means that the pneumonia is probably affecting in one or more lobes of the lung. So I really want you to review that the right lung consists of about 3 lobes, and we have the left lung only composed of 2 lobes. Now, if you're going to see maybe in the chest x-ray stating that the patient may have some multi-lobar consolidation, then it's suggesting that this is much more a severe illness, and this is involving multiple lobes, maybe involving both lung fields. So the 5 lobes altogether. Now, we also have the sputum analysis, which is very important for us to collect if the medical provider has ordered for us to do so. And this is going to be needed for us to probably get that requisition to do, or for the medical, the lab people to do the gram staining and culture. And this is going to help with a specific type of bacteria causing the infection. So the identification really is the key here. Now, keep in mind, guys, that when you are collecting the sample, the sputum sample, make sure that you are obtaining a quality sample, meaning you are obtaining that sample that has no saliva mixture in it. It's not contaminated with other stuff. And make sure that you have instructed the patient to rinse their mouth with water first before they're going to do their coughing and expectoration. That this will actually going to prevent the mixture of the expectorate, the mucus, and with the surrounding bacteria in the mouth. Okay. And as I have said in the previous lecture regarding the diagnostic tests, make sure that this is something that you will be doing early in the morning, or as soon as the patient gets up in the morning, then make sure that this is collected. Okay. Again, make sure that you instruct the patient to rinse their mouth first. But if this is not really effective, let's say maybe the patient is not able to follow the instructions, and of course, probably they're not really able to collect the quality sputum sample, then we need to communicate with a medical provider. Maybe the respiratory therapist will be able to collect the sputum sample through suctioning, okay, nasotracheal suctioning, which would be a whole lot better type of specimen. Now we're also going to talk about the blood cultures. So what is the importance of the blood cultures here? Well, because when we are talking about pneumonia, this is an infection, okay? So before we're going to treat the patient with the antibiotics, we want to make sure that we have at least collected the blood specimen for culture before we are going to start any kind of antibiotic therapy. And we want to make sure that this is done before ICU admissions or any specific risk factors, let's say cavitary lesions or leukopenia or alcohol abuse or chronic or liver disease or asplenia. So these are the things that you need to also consider. Now, there's probably some immunologic tests that will also help detect the microbial antigens. And so make sure that this is going to be carried out as well. And so this can be done in so many forms. It could be done through the serum or sputum or urine in order to identify the causative organism. Now, at this point, we're going to talk about the treatment. Well, yeah, the treatment is very important here, of course, with the administration of the antibiotic therapy. And this is going to be done according to the empirical type of recommendations. So the medical provider here will prescribe to start with a broad spectrum antibiotics, and this is going to be based on the common causative organisms before the blood or sputum culture comes back with the results. All right, so again, it can be, to start the antibiotic therapy, it can be empiric, and once the sputum specimen or the sputum culture is now showing the microorganism, or let's say the blood culture has identified the infecting microorganism, then there might be a need for the medical provider to switch into a different kind of antibiotic where the microorganism is sensitive to. Okay, now we'll also tackle on the oxygen therapy. So what we are doing here is that we're going to monitor the patient's level of oxygenation to see how low they are, or if they're improving, or maybe they are deteriorating. And so we're going to have to go through the protocol, starting with the low flow oxygen first, and then we'll have to notify for any changes if the patient would really require much higher level of oxygen concentration. So that definitely would require notification in order for the physician to be aware that the patient's condition is worsening. All right. Now, if there is a need for transitioning into the non-invasive ventilation, let's say with the use of the BiPAP, then this can possibly work for the patient, especially if they are developing hypoxemia and they are not really tolerating the regular delivery oxygen methods like the mask, the non-rebreather, or the high flow. And so maybe this is something that they can benefit from. And so if there is no need yet for an immediate intubation, then this probably would work for them as well. Now, if in case the non-invasive ventilation therapy is ineffective, then maybe the medical provider will suggest the mechanical ventilation endotracheal tube placement. And so here we have our ventilation strategy. Most of the time, we're going to have to set low tidal volume using about 6 mL per kilogram of the ideal body weight. Okay, so this is the recommendation for those patients with diffuse bilateral pneumonia and also with an accompanying acute respiratory distress syndrome. All right, so this is our initial recommendation for the mechanical vent. Now, guys, as you are going to really participate in the care of the patient, maybe you might be taking care of this patient for the next 2-3 shifts, then, or also with the care team, make sure that you are advocating about the patient's early ambulations. Okay, so this is really gonna encourage the movement as soon as the patient is clinically stable, and this will really shorten their hospital stay and will lead into better outcomes as well. Now, part of the care here is to check the patient's vaccination status, ensuring that the patients are up to date to their influenza and pneumococcal vaccines before their discharge. And also with the smoking cessation, this is very helpful. We are going to advise the patient, assist the patients who smoke in order for them to start quitting. Okay, again, it's just a matter of some preliminary teaching for this patient. Maybe they are very resistant about the smoking cessation because they don't like the effects of stopping smoking. They are probably afraid that they might gain a whole lot of weight once they stop. Well, there are different modalities on how to do that. Okay, and so you initiate that conversation with them that they definitely need to stop smoking whenever they're going to encounter any of these serious lung problems. Now, respiratory hygiene, this is very important, guys, especially in the outpatient or let's say emergency settings. We really need to encourage our patient to do hand hygiene and make sure that they're also using the mask if they have the pneumonia, and also with the use of the tissues for coughing, in order to prevent them from spreading the infections. Now, guys, let's talk about the possible complications, and there are so many complications that can arise from having the infectious pneumonia. So one of those is pleural effusion. Well, we know that this is the fluid buildup between the lungs and the chest wall, which can really complicate the pneumonia. So you have to keep an eye on this one. Pleural effusion, not a good thing to have. Oops, let me erase that. Now there's also the shock. Like I've said earlier, the body will try to defend itself from the infecting microorganism, of course, with the congregation of the neutrophils and also the chemical mediators going into the site of infection, right? This will trigger the systemic inflammatory response, or known as the SIRS, okay? This is our preliminary step or phase in the shock, septic shock. And so again, our main concern here is the persistent low blood pressure because of the widespread vasodilation. And again, we definitely need to keep an eye out, make sure that we are delivering those antibiotics that will be prescribed stat in order to fight off the infection, and also the boluses or maybe the vasopressors that will be ordered to prevent the shock to occur, or maybe to counter effect the shock. Now we're also going to talk about the empyema as one of the complications here, and this is the collection of the pus in the pleural cavity, and this is going to require drainage and treatment, and also the super infection, which is going to probably these are your pericarditis, the bacteremia, or the meningitis. So these are the secondary infections once the patient has the pneumonia. Now, delirium, what is this? This is the acute confusion that is considered a medical emergency. Guys, if you are the nurse taking care of this patient that has that pneumonia, and out of nowhere the patient develops the delirium, that is a bad sign. That's an ominous sign that the patient is having a severe type of infection, and there might be an underlying systemic infections that could have been masks or maybe some other complications hiding it. Okay, now also there is also a problem. This is a problem that is very common in the elderly population, especially if they're going to develop the delirium. This is a marker that they have developed a much serious issue that would really require immediate attention. Okay, now the delirium can also lead to some other problems. Maybe the patient could actually harm themselves. They can lead to falls, self-injury. They might start pulling IVs, could be nasogastric tube. They probably would not really be able to cooperate. They will be combative as well. So again, delirium is not a good sign at all. Now, another complication is atelectasis, or the lung collapse. So this is caused by the mucus plugs blocking the airways, and also the alveoli or the terminal bronchioles. Now, guys, we'll talk about the nursing assessment and interventions this time. So part of your care here is to really get a detailed medical history. So as much as you can, gather the detailed past and present medical history, because understanding the possible causes of pneumonia and also the patient's background can really help us tailor the management and to plan effectively. Now, we also need to ask the patient about what possible causes their infection. Have they been exposed to anyone with a respiratory infection, or maybe they have traveled recently, or maybe traveled to areas known for specific outbreaks, or have they had some local disease trends? So those are the things, or maybe an outbreak, simple outbreak, or let's say exposures. Have they been exposed to any kind of chemicals or animals or environments that may contribute to respiratory issues? Now, we are also going to document for any recent type of respiratory infections. We're going to have to obtain their full medical and social history and their risk factors in order for us to identify those precursors, or let's say contributory factors to the current conditions, and make sure that we are obtaining the full medical history in order for us to identify those conditions, maybe a COPD, or it could be diabetes or heart disease, or maybe if they have some form of social history, maybe smoking, alcohol use, or their living conditions. Are they living in a very crowded living environment, or are they any kind of occupational exposures or hazards at work? So make sure that you have this information as well. Or their other risk factors. Are they compromised? Are they getting any of the immunosuppressant medications? Let's say maybe they're taking chemotherapeutic agents, or maybe taking immunosuppressant medications because of a organ transplant. Maybe they have received an organ transplant about 2 months ago, 3 months ago. And so they're really prone to developing this, or maybe if they have HIV or AIDS, this can really predispose them to getting the infection. Now, guys, we are going to note here about the purulent sputum, or it could be increase in the amount of the sputum that they're expectorating, and also the fever, the chills, the pleuritic chest pain, and the dyspnea and tachypnea. These are important manifestations that we need to pay close attention to, because the pneumonia can really present in so many ways in order for us to document. And so if we are talking about the sputum, we have to identify about that. What color is it? Is it very thick? And also observe the consistency. Now, is this more of like an increasing amount? Have they had more of the sputum expectorated within the last 24 hours? So make sure that you are assessing that as well. Also, their elevation of the temperature, maybe they're developing the chills overnight. That really is going to signal that there is an infectious process going on. Now, we're also going to observe the patient for any breathlessness, or also illnesses patterns in the family. So we have to investigate further if there is some kind of like spread of infection among the family members, right? And we'll have to ask anyone if there is also somebody at home that is sick, all right? And we will be able to identify the infectious nature of the pneumonia that they might be having. Now, we're also going to have to assess or obtain the medications that the patient is currently taking and the allergies of those medications. And so we are going to be able to identify and to safeguard us from giving medications that may contraindicate or may have some interactions with those medications, right? And also with the allergies, we want to make sure that we have investigated this patient, because we don't really want to cause any more serious occurrences in this patient with anaphylaxis. No, we don't want any more of that. Now, part of the assessment here is for us to auscultate the lung sounds of the patient, make sure that we have that obtained as well, to see if there is a rapid change in the lung sounds. Maybe they are now developing rhonchi or wheezes. Wheezing, hoarse crackles? No, we don't want that. We don't want that. This is typically going to signal that there is now worsening patient condition. Now, talking about the interventions here, we are really going to have to monitor the patient's condition. So we are going to monitor for the patient's breathlessness, their hypoxemia, if there is appearance of cyanosis, or if they are now getting confused. So maybe before, when you were the nurse working for this patient yesterday, and then when you come back for the same patient, then they are probably now confused. That's a big change. All right. So that definitely will call for the medical provider's attention. Hey, our patient is really deteriorating. She is now confused, unable to really recall the events within the last 4 hours. They cannot even recall what day it is today or the time. And so this could really signal that there is now an underlying issue. Now, we're also going to have to check the patient's arterial blood gases, their oxygen saturation. We have to really determine their oxygen levels, and also to see for those imbalances so we can address those real time. And we have to administer the oxygen with humidification. Make sure that we are also checking the patient's partial pressure of the oxygen, or also the saturation. And we want to make sure that we are addressing the hypoxemia. Now, part of the care here is to humidify the oxygen. If in case the administration of the oxygen exceeds 4 liters per minute, okay, make sure it is humidified in order to prevent mucous membrane dryness. Okay, now we are also going to be cautious in the delivery of the oxygen, especially if the patient may have a history of COPD. Remember about what I said about the COPD? patients, they're only going to require minimal amount of oxygen, low oxygen concentration, let's say 1 to 2 liters at most, and we are going to maintain their oxygen level with this range from 88, maybe 90%, or 90 or 92%. This would be the safe range for them, because if we are going to deliver them much higher concentration, this will lose their drive to breathe and they're going to stop breathing. And so make sure we're going to administer them a low concentration. Okay. And better yet, with the use of the Venturi mask, because there we can definitely use the safe amount of oxygen that they can get. Okay. Now, we are going to also talk about the maximum position, especially putting them in a sitting upright position, especially when they are in distress, to make sure that we are also allowing them to reposition themselves in bed, to allow, what do you call this, movement of those, what do you call this, thick, tenacious secretions in the alveoli. All right. Now, we'll talk about the collection of the sputum sample. I actually mentioned this earlier. Make sure that this is collected correctly. Like I've said, should be collected early in the morning. Have to make sure your patient does the oral care first. Have them rinse their mouth and make sure that they are not mixing the sample with the saliva. Okay? And place in a correct sterile container. Now, we're also going to encourage the patient to do the coughing and deep breathing exercises. This is important, guys. And if in case they're not going to be able to cough out the phlegm or the sputum, thick, tenacious sputum, then they need to be assisted with the use of the suction. Okay? It could be with the use of the nasotracheal suction in order to get rid of the thick secretions. We're also going to have to encourage them to increase their oral fluid intake unless contraindicated, because this will really help thin out their mucus secretions. And we're also going to do that because of the fever that they're experiencing. They might be losing a whole lot of the fluid through insensible water loss, right? Because of the rapid respirations, they're going to have that increased insensible water loss. So make sure that we are encouraging them to take a whole lot of water. Now we are also going to incorporate the use of airway devices. And this is something that is highly recommended by the respiratory therapist. And I've mentioned this about the use of the positive expiratory pressure device. One of those is the Acapella. I remember actually showing this to you way back. This is that device that has that rubbery looking, let me find that page for you. Let me go back. Let me just do this real quick. Hey, here you go. So this is that device here that I'm talking about. That device we call Acapella. So this is going to require the patient to seal the mouth, seal the mouthpiece with their mouth, and they're going to have to inhale deeply. And once they do that, the device can deliver vibrations into the patient's airways. And once it does that, it will cause dislodgement of the mucus inside the patient's airway, and they're going to end up coughing that out. All right. Now, let's go back to that slide 276. I think we are here. Yes, so that is the Acapella. Another modality here is to have the chest percussion and also the postural drainage, or the use of the vibration kind of like vest. And this is going to be done by the respiratory therapist to dislodge those thick secretions in the lung fields. And definitely we have to encourage the patient to mobilize as early as they can tolerate as well, in order to improve their ventilation and to clear their secretions, and also to reduce their risk of the lung collapse. Okay. Now, part of the care here is to teach them about the chest splending, especially when they are coughing, in order to lessen the painful sensation. And another is to avoid suppressing the cough. Okay. So what is this? Maybe they probably would be taking some of those cough suppressants or antitussives. No, we don't want that. Okay. This will allow trapping of those mucus secretions in the alveoli, and this can prevent, or it can further cause multiplication of the infectious process in the lung fields. Now, we're also going to have to encourage bed rest into our patient, especially when they are having the fever, in order for us to decrease the patient's metabolic demands. When they have that fever, remember that they're going to end up with rapid breathing, rapid heart rate. Yes, they're going to be exhausted for that. And so bed rest is very important around this time. Now, we're also going to talk about the administration of the antimicrobial agents, which is really one of the highlights. Because of the infectious process, we really need to eradicate that infectious microorganism. All right. Now, moving into the patient education. And this is something that you can start even when the patient is still in the acute care setting. Okay. Please take note of this. The patient education is not limited during the discharge process. Okay. This is very important for you to make sure that you are imparting the knowledge, and also making sure that they understand what you have been teaching them. So for example, if this might involve with the use of the incentive spirometer, make sure that they're able to use the device effectively and properly or correctly. Now, guys, we're going to talk about the patient education, let's say the proper or the compliance regarding the antibiotic therapy. This is very important, okay? Make sure that you recommend this to your patient in order to prevent antimicrobial resistance or resistance to the antibiotic. Now, we're also going to talk about informing the patient that fatigue can occur even after they had the pneumonia. Okay, so this is something that the body will undergo. This is just a normal physiological response. The patient will have that because it's still in the process of repairing those tissues that need healing. Now, also, we're going to have to gradually increase their physical activity after they are much more stable. Okay, so make sure that they are doing that to enhance their breathing and also minimize the risk of immobility. Yeah, immobility means more complications. We don't want that. Especially if the patient is in the hospital, immobility equates DVT, deep vein thrombosis, which is a very common complication to patients that are in the hospital. All right, we don't want that either. Now, we're going to have to talk about performing lung clearing exercises. And this is very important in order for them to clear their lungs and also enhance the full expansion and also the functionality of their lungs. We're also going to have to talk to them that there is going to be a need for them to have a follow-up chest x-ray after 4 to 6 weeks. Okay, so this simply means that this is going to be done as an outpatient in order to reassess the lung clearance and also to detect any potential underlying causes, maybe tumors. So make sure that they're going to comply with this follow-up appointment. Now, quitting smoking is a big deal, okay? We are really going to highlight here the detrimental effects of the cigarette smoke on the lung defenses and also the lung function, okay? Now, we're going to have to talk about the maintenance, or we're going to have to recommend maintaining natural resistance through their balanced nutrition at home, adequate rest periods, and also suitable physical activity, and also making sure that they have taken the recommended medications upon discharge in order for them to prevent the recurrence of the respiratory infection. All right. Now, part of the care here is to really avoid fatigue and extreme temperatures and also excess alcohol, because these factors can increase their susceptibility to the pneumonia. Make sure that they have adequate rest periods and no rapid changes in their environmental temperature as well. And alcohol definitely need to be stopped or lessened around that time. Now, we're also going to talk about the need for them to get the pneumococcal vaccine or the flu vaccine, especially if they are at a higher risk. We want to make sure that they are screened. If in case they have not received it yet, make sure that we're evaluating their eligibility, and we're going to have to support for the vaccination with the pneumococcal and the influenza vaccines, which is really associated with a decreased hospitalizations and also decrease in the mortality from the pneumonia and influenza. Now, guys, we're also going to talk about we're going to have to advise the patient from refraining from close contact with the individuals with people experiencing upper respiratory infections for several months. Okay, so we don't want them to get exposed by those people. And another thing is we're going to have to prioritize the teaching on hand hygiene, respiratory hygiene, especially after contact. Careful hand washing is very important here, guys. Now, as we are going to recap regarding the discussion on pneumonia, again, in the pneumonia care, nursing will have to prioritize on the regular assessment of the vital signs, the respiratory status, the delivery of oxygen, and also checking the patient's saturation levels in order that we can monitor for any progression or deterioration. And the nursing interventions that we're going to have to provide will be geared into the administration of the antibiotics, could be the bronchodilators as well if they have some COPD along with the pneumonia. And we're also going to have to provide respiratory support like oxygen therapy or let's say nebulization. And it is very crucial for us nurses to monitor and also address some complications, maybe atelectasis or let's say sepsis. These are something that can happen readily into our patients. So we want to make sure that we are proactive in delivering those interventions, make sure that we are adequately hydrating our patient, mobilizing our patient, and make sure that they have they're doing the respiratory exercises. Now, before we end, we definitely make sure that they are receiving the correct information, the patient education, and also include the caregiver, their family members, to be educated, especially with the treatment that they are going to be receiving at home, the exercises that they should be doing, like coughing, deep breathing exercise, and make sure that the patient will adhere to the medication therapy. Make sure that they complete whatever has been ordered, and also make sure that they recognize those symptoms of worsening, or let's say, worsening their manifestations, which is very important in order that they can get the necessary help as early as possible. And so that is the end of our discussion today. We will be talking a different topic tomorrow, but we will be posting the name of the topic through our thumbnail. So please keep an eye out on that one. So I really appreciate your time attending this short class, and I will see you again tomorrow. You take care. Bye-bye.